Hello, my name's Dr. Ollie Hart. Personalised care is a concept and an approach that I believe is essential to generating optimal health and well-being for everyone. Understanding what it is, why it's worth pursuing, and how to mobilise our current system to achieve it is certainly a challenge. But I think it's a challenge that's well worth getting stuck into. There are huge benefits to our workforce, to our NHS, and to the people and communities that our NHS serves. This short presentation is aimed at stakeholders who are involved in bringing this personalised care ambition to life. Commissioners, practitioners, managers, leaders from the many range of stakeholders involved. I think what we need is a shared common narrative and a real common sense of purpose. I've spent the last 10 years in primary care and I've experienced across a range of roles, from provider, commissioner, innovator. I think this gives me a strong and wide-ranging perspective, and I'm currently a GP partner, I'm a PCN clinical director, and I'm an educator in person-centred care. So what is personalised care? I believe it's an ambition. It's written really strongly throughout the NHS 10-year plan that came out in January 2019. And in that document, these are some quotes I pull out. So they suggest it's offering people choice and control over the way their care is planned and delivered. It's based on what matters to them and their individual strengths and needs. It's moving away from a one-size-fits-all health and care system, which simply cannot meet the increasing complexity of people's needs and expectations. And they detail that evidence shows that people will have better experiences and improved health and well-being. So personalised care represents a significant shift in our focus, a mindset shift and a shift in what we do, moving from reactive professional-led illness-focused care that you might be saying is heavily medicalised towards proactive asset-based partnership and holistic care, what you might call a more socialised approach. It's not one without the other, but it is a shift towards a more person-centred way of doing things. So why is this shift in locus of control so important? Why does it matter that people are conductors of their own care? Why not just leave healthcare to the highly trained experts? Well, I think we have to look at what contributes to great health and well-being in people. When people have studied this, they come up with three core factors. Healthcare itself, the social context people are in, and what people do for themselves. Sure, there are other factors like our genetics or our macro environment. So if we're living in the middle of a global pandemic, or if you're in a war zone, your health is likely to suffer. But generally, these are the three things I think that we can control and we should be mindful of. So let's look at these contributing factors in the two main scenarios we mostly see in healthcare. In the acute situation, the sort of typical thing we see where people present with injury or trauma, a sort of sudden new infection or new diagnosis of cancer, acute inflammation of joints or of blood vessels, or a mental health crisis. In this situation, the relative contribution probably looks a bit like this, where healthcare quite rightly predominates. There's a bit that people do for themselves, there's a bit their social context has a part to play, but generally what healthcare does in terms of diagnosing people, giving advice, offering treatment and mobilising resource has the biggest impact and produces the best outcome. However, more and more of the conditions we're dealing with and managing now are falling into the chronic model. Things like metabolic dysfunction, diabetes, non-alcoholic fatty liver disease, the chronic vascular conditions affecting our brains and our hearts and our peripheral circulation, chronic respiratory things like COPD and asthma. Chronic pain's a real biggie, isn't it? Whether it's neurological, musculoskeletal, a lot of people living with chronic pain and chronic mental health conditions. And in these conditions, the evidence reveals a very different relative contribution of each bubble. Sure, health has an effect, being able to monitor health status and changes, but outcomes are far more influenced by what people do for themselves and the social context they find themselves in. In fact, evidence from the King's Fund and Health Foundation and organisations like that, which have been repeated again and again, suggests self-care may be 3 to 5 times more important than the healthcare contribution. So if we're interested in high-performing systems, we need to pay more attention to building people's skills, knowledge, confidence and motivation. And considering what Michael Marmot describes as the social determinants of health. Things like the quality of our housing and work, our social connections, the relative covering of our finances, whether we have physical access to facilities that can support us looking after ourselves, and if we need it, for more social care. And what's interesting, isn't it, is that actually this chronic disease approach, long-term condition management, makes up at least 50% of primary care, and they say 70% of the whole cost of the NHS is absorbed in this sort of work. We need to develop an approach that maximises the potential of each bubble if we want our systems to perform well. So I think health coaching is all about supporting and developing the green self-bubble. It's about supporting people to perform as well as they can in their health and wellbeing context. You know, in any situation where people's performance is taken seriously, coaching strategies and approaches are always employed. You won't find any professional sports clubs or big business that doesn't work without coaches. You know, can you imagine a Premier League football club trying to get the best out of their players without employing coaching techniques? Now, link workers, I think, are about connecting people with the right resources in their social context to enable them to perform as well as they can. We know that performance is very related to our social context, so connecting us with the right ongoing resources and environments is crucial. Now, for many people, the interplay between the self-care, the social context and the healthcare input is extremely complex, and care coordinators help people to make sense of all the contributing parts. A bit like a PA for a busy executive, they ensure people can keep track of all the self-care regimes and appointments they have, make sense of information and generally be the person on your side. So these three roles represent parts of the new roles that the NHS is trying to establish in how we build this systematic chronic disease model. There'll be some overlap between them, of course, but I think viewing the roles they have to play it can be really helpful to think what we need to get going in our system. If we grow the role that people play, not only do they become an increasing resource for themselves, we start to develop an asset that can feed back into the system and the services on offer. So peer support is a powerful and really effective tool. I'd say it's much underutilised in the NHS. Our patients may well be our biggest untapped resource. And let's go back to supporting the acute model. Primary care networks have access to a range of other new roles that are available to support the acute model too. Physicians associates, paramedics, advanced care practitioners in many forms, first contact physiotherapists, mental health workers and others, and pharmacists. And not only do these roles grow the capacity of the health provision and offer a very welcome pressure valve for the frontline primary care teams, they can also release senior clinicians to have more time for high value roles, things like complex case management, the most complicated, supervising, training and offering leadership. And if our mission is to create systems that make the best of our resources to produce the best results, I think we need to start thinking about how this all fits together. So I wanted to just focus a little more on the green and blue bubbles and how these new roles can support these. So I think the focus of health and wellbeing coaches is to build this self-management capability. Now, it could be healthcare professionals with coaching skill sets to do this, and it's such an important aspect of long-term condition management and chronic disease management. I think all healthcare professionals should understand and utilise coaching skills. However, building an individual's personal skills, knowledge and confidence often takes time, plenty of listening and understanding of the individual. So it does make sense for a dedicated role to develop a real focus on this aspect of the system. These people need to become experts in supporting behaviour change. They will typically use the coaching expertise of things like raising awareness of the current situation and considering new ways of thinking and doing that really fit for the person in their context and support people to put changes into action, maybe very small steps to start off with and then building it up. It's a real skill to understand the right support at the right stage of people's personal wellness journey. And as we've seen, this bubble is crucial in a high-performing chronic disease model. So this role, perhaps previously overlooked, is absolutely critical. And to the blue social bubble then. So a social prescribing link worker's role, I believe, is to help people to connect with and make the most of locally available assets. This helps people to maintain the behaviour changes in their local environment and to build sustainable habits that are wired into their surroundings and the relationships they have. So as well as this, though, they also, I think, social prescribing link workers have a crucial role in, and especially as we come out of this pandemic, in identifying the needs of local people and where the facilities are lacking, and help to build the most appropriate facilities and support. And this is where I think we have to be honest that for an equitable approach, some communities are going to need more input to build and sustain necessary local assets than others. Although I do support an asset-based community development approach where local communities are supported to grow their own assets, building on people's current capabilities and facilities. It's the coaching principle of enabling rather than doing to people. So just to briefly finish, I'm going to just give this real-life illustration of the network that I'm clinical director of, Heeley Plus Primary Care Network. It represents a partnership of 8 GP local practices working with a huge range of local community anchor groups, our voluntary sector trusts, schools, businesses, community nurses. We're served by a number of hospital trusts, so we're trying to collaborate everybody together. And this, I love this picture. It's a Boulders Festival, which is organised by Heeley Trust, one of our local voluntary sector organisations, and it just illustrates how people love to come together and support each other. So we will aim to be driven by the needs and wishes of our local 50,000 people. We've got new resources available for us, for leadership, clinical directors like me and our network manager, and we're developing as a network. We've got some funds to help stakeholders to build understanding and trust, and we've also got these primary care network roles to support our aims. And by 2024, the annual budget for these roles for our network will be 1.1 million a year. It will cover probably 25 whole-time equivalent new staff. And it just makes me wonder how we'll make best use of them. Whatever we do, these new roles, these new networks, well, we're building on the fantastic base that we already have of highly capable people in the NHS and the caring facilities in health and caring roles already. There's no doubting the commitment and dedication of these people to help other people. I believe this shift towards personalised care is our opportunity to coordinate our efforts, to focus our considerable energy and resource where it will have most impact, so we can reach new heights. So to conclude, I believe we have to understand why we're pursuing personalised care and then how we can put it into action. We need the right kind of resources, offering the right support for people in the right way. And crucially, our systems need to be set up to encourage personalised care to grow. It won't work unless the systems allow it to happen. We need measures, contracts that actually direct people and processes towards personalised care happening. I think if we get this right and we do bring personalised care to life, the prize we have is flourishing people working in partnership, sustainable systems, the NHS and caring systems, and strong local communities. And I really believe that's a prize well worth fighting for.